Welcome to the Deep Dive. Today we're tackling something really pervasive and maybe often underestimated in cancer care. I'm talking about the significant gastrointestinal issues that can really impact patients, sometimes, years after their main treatment.
That's right. We see it all the time.
Yeah, we're talking figures like upwards of 95% for people having traditional chemotherapy and maybe 20 to 50% dealing with chronic bowel problems after pelvic radiotherapy.
It's a huge number.
It is, and it sticks with them. I know you probably heard this quote or something like it, but it's never been the same.
Absolutely. That quote really hits home, doesn't it? It highlights how these aren't just temporary side effects. They fundamentally change quality of life, daily routines, even social interactions.
Exactly. So our focus today is a really key resource for navigating this. The British Society of Gastroenterology's practice guidance on managing these GI symptoms and complications from cancer treatment, both acute and chronic.
It's a vital document,
Yeah.
and that's what we're diving into.
Right, we've got the BSG guidance here, and it's specifically written for healthcare professionals like you, listening gastroenterology consultants, who are really dealing with these treatment fallout issues.
Mm-hmm.
Now, it's important to say, while it's best practice now, the evidence base is still, well, growing. So a lot of recommendations come from expert consensus. Think of it as the collective wisdom in our field right now.
Precisely. Our mission here is to pull out the most critical, the most nuanced insights from this guidance that are directly relevant for your practice. We want to clarify the tricky bits and give you a really comprehensive, in-depth understanding.
Okay, so what's the plan for this deep dive? First up, patient perspectives. What are patients actually telling us?
Crucial starting point.
Then we'll get into the pathophysiology, the why behind it all. After that, assessing GI symptoms, but from a patient-centered view, using validated tools, thinking about differential diagnoses.
Which leads nicely into diagnostic tests.
Exactly. Using tests strategically to pinpoint the real physiological problems. And finally, the big section, commonly encountered conditions and how to manage them.
Yeah, covering pain, specific therapies like chemo and radiotherapy, lower GI functional stuff, LARATs, radiation proctopathy.
Fistula, GVHD, neuroendocrine neoplasms, and palliative care considerations too. It's a lot to cover.
It is. Let's start with those patient perspectives then.
Sounds good.
So the BSG guidance really puts a strong emphasis on informing patients proactively, talking about potential long-term GI side effects, ideally right from the start of their cancer journey.
Before treatment even begins.
Ideally, yes.
Yeah.
And developing personalized care and support plans is key, so patients know what might happen and, crucially, how to get help after their main cancer treatment is done.
And it's not just listing physical symptoms, is it? The guidance really pushes for ongoing holistic assessment, thinking about the emotional, social, occupational, even financial impact these GI problems have.
Absolutely. It needs assessing both during and after treatment. It's a powerful point. These bowel issues don't happen in a vacuum. They affect everything.
Yeah, they ripple outwards.
Precisely. And the guidance says every clinician involved has a responsibility here to actively look for unmet needs, really listen to concerns, validate them, and know where to signpost patients for the right support. It's about being proactive, not just reactive.
The document gives some pretty stark examples, things we probably all recognize.
Mm.
Patients feeling their ongoing needs aren't met, the sheer persistence of bowel issues despite trying things,
Mm-hmm.
and that struggle, sometimes for years, just to get a diagnosis for something like bile acid malabsorption. We know how much that can affect quality of life.
It really can. And what's quite insightful is the data they include from Macmillan Cancer Support's holistic needs assessment.
Oh, yes. What did that show?
Well, for patients with upper and lower GI cancers, the most frequent concerns weren't always physical symptoms. Often it was questions about the diagnosis, the treatment itself, worries about the future, the impact on their partner, that general sense of uncertainty.
That broader context is so important for us to keep in mind, isn't it?
Definitely.
And for us as gastroenterologists, the guidance gives clear triggers for referral. Things like frequent loose stools, that really disruptive nocturnal defecation, any fecal leakage, rectal bleeding.
Or just when bowel function is clearly dragging down their quality of life or mental health.
Right. Those are the times where specific expertise is really needed. Okay, let's move into the foundations. The pathophysiology.
Understanding the why is absolutely fundamental for good management. The guidance stresses that optimal symptom control really depends on identifying the specific physiological deficits caused by the cancer treatment.
Which means testing, right? Not just guessing based on symptoms.
Exactly. It often needs targeted, appropriate diagnostic testing, moving beyond assumptions.
And it's rarely simple, is it? The guidance points out and we see this clinically, that most patients with ongoing GI symptoms after cancer treatment have multiple things going on.
That's a key takeaway. It's usually multifactorial.
So how do these treatments actually cause problems?
Well, think about cytotoxic chemosystemic effects, targeted therapies, specific GI effects, radiotherapy localized to potentially long-lasting damage, and GI surgery itself. All these can kick off a cascade of issues. Inflammation, both acute and chronic, microvascular damage affecting absorption and motility, direct nerve damage.
Altered sensation function.
Exactly. Changes to the mucosal lining, its barrier function, denervation impacting control, changes in secretions like bile acids, pancreatic enzymes. It's a whole spectrum.
The guidance lists the known physiological abnormalities, which is helpful for thinking diagnostically. Things like lactose intolerance, other disaccharide issues, bile acid malabsorption, which we mentioned can be hard to diagnose.
SIBO, small intestinal bacterial overgrowth, pancreatic insufficiency, PEI, altered gut transit either too fast or too slow, increased susceptibility to infections, and direct drug toxicities too.
A pretty comprehensive list of possibilities.
It is, and that leads us into the assessment side.
Right, GI symptoms and that patient-centered assessment. The guidance strongly recommends using validated symptom questionnaires routinely, like the GSRS, the Gastrointestinal Symptom Rating Scale, and PROMS, patient-reported outcome measures.
Using these tools regularly, maybe every visit, gives a much more objective picture than just relying on anecdotal chat.
It ties back to capturing that lived experience we talked about. And the guidance makes another critical point, especially for patients treated with curative intent.
Always consider recurrence.
Yes. Maintain that clinical suspicion. Actively consider and rule out cancer recurrence as a cause for new or worsening GI symptoms. That's absolutely paramount.
Absolutely. And also, don't forget to investigate conditions not related to the cancer or treatment. Could it be something completely new? A primary GI disorder?
That's a good point. The guidance is very clear. Relying on individual symptoms or patterns alone isn't reliable for diagnosis here.
No, because the overlap is huge.
Exactly. The document shows this well with tables. Different physiological disorders can present very similarly. Think about bile acid malabsorption, carbohydrate malabsorption, PEI, SIBO. They can all cause chronic diarrhea, bloating, pain.
And that overlap is precisely why a comprehensive systematic investigation is essential, especially if symptoms aren't responding to simple initial treatments. We often need to dig deeper than empirical trials.
The guidance also reminds us of the sheer variety of symptoms possible upper and lower GI, pace changes, swallowing issues, right through to incontinence and bleeding.
It's a wide spectrum.
So our assessment needs to be broad,
Yeah.
working with the patient to identify everything that's distressing them. And things like visual analog scales for pain or the Bristol stool chart, they seem simple but can be really useful communication tools.
Definitely provides a shared language. This comprehensive symptom picture then leads us straight to diagnostic tests. The guidance is explicit. Clinical acumen alone isn't enough here.
However experienced we are.
Right. We can't just rely on intuition based on symptoms.
And he hammers home that point again.
Yeah.
Different cancer treatments often cause a similar set of treatable physiological changes. Bile acid diarrhea, carbohydrate intolerance, PEI, SIBO, infections.
Identifying these specific issues is key for tailoring treatment effectively.
What I found really important was the emphasis on getting clear, specific diagnoses. Because if a patient has multiple issues, which is common, a lack of response to one empirical treatment can be misleading, can it? It might not mean they don't have that condition. Maybe the dose was wrong, maybe side effects mask benefit, maybe something else is going on too.
Exactly. Clear diagnoses guide targeted treatment and improve adherence and outcomes.
Okay, let's get into some specifics then. Commonly occurring conditions and the diagnostic and treatment approaches from the guidance. Starting with nutrition.
Always fundamental. The guidance advises proactive supplementation trace elements, multivitamins for patients on restrictive diets, at least until a dietitian can review them properly.
And if long-term dietary changes are needed,
Then that formal dietitian review is crucial to ensure nutritional adequacy.
makes sense. What about suspected PEI, pancreatic exocrine insufficiency?
The guidance suggests a practical approach, a 10-day trial of PERT pancreatic enzyme replacement therapy at an adequate dose. But importantly, only after educating the patient properly on how and when to take it with meals.
That structured trial usually clarifies if it's helping.
Generally, yes. It helps assess clinical benefit.
And for those patients with multiple diagnoses happening at once,
The advice is caution. Introduce treatments one by one. Carefully document the symptom response to each before adding the next, a stepwise approach.
Okay, pain. That's a huge issue for many.
It really is. The guidance covers various causes of chronic pain after surgery or radiotherapy strictures, adhesions, fibrosis, obstruction, but also highlights things like fecal loading and SIBO as potential contributors that might be missed.
And always keeping recurrence in mind with new pain.
Always. And the guidance stresses the urgency of surgical assessment if you suspect complete obstruction or severe pain, like acute small bowel obstruction or ischemia.
And overall, pain management here really needs that multidisciplinary approach, doesn't it? Gastro, surgery, pain specialists, nutrition teams.
Absolutely. Collaboration is key.
Right, let's talk specific therapies. Cytotoxic chemotherapy. What GI issues does the guidance flag most often?
Frequently things like lactose intolerance, SIBO, bile acid diarrhea, and PEI. And it says investigating new symptoms during chemo is feasible and often helpful.
What about managing acute chemodiarrhea?
While waiting for stool results to rule out infection, initial cautious use of loperamide is usually okay, but monitor closely for toxic dilation. And importantly, temporarily stop any suspect oral anti-cancer drugs until the oncologist reviews.
And for severe toxicity, say with capecitabine or 5-FU.
Urgent CT abdomen pelvis is needed to rule out enterocolitis. That's a serious complication requiring prompt action.
What about the newer targeted therapies? Small molecules.
The guidance gives specific examples. PEI is common with sorafenib. Bile acid diarrhea is often seen with lenalidomide. Knowing these associations helps guide our thinking.
Good to know. Moving to radiotherapy effects. Any risk factors?
Yes, smoking and low BMI increase the risk. Addressing these beforehand, maybe with dietary counseling or protein supplements, might help.
And managing acute radiation diarrhea.
The guidance suggests specific probiotics might offer some relief. And a high-fiber diet might potentially reduce toxicity risk, especially with pelvic radiation, for acute upper GI symptoms post-treatment like bad mucositis.
Key is ruling out infections, first viruses like HSV, CMV, or extensive thrush. Symptom management follows a kind of WHO ladder approach for pain.
And nutrition.
Early referral, if there's a malnutrition risk. Local treatments like special mouthwashes can help mucositis pain. But a big caution, don't dilate upper GI strictures until you've ruled out malignancy or the MDT agrees.
Right. What about post-upper GI surgery issues?
Understanding the pre-op GI history is important. For anastomotic strictures, endoscopic dilatation is usually the first step.
Reflux.
TPIs for acid reflux, maybe short-term prokinetics. Sucralfate can help with bile reflux. But interpreting things like gastric emptying studies post-surgery needs caution. Normal ranges aren't well defined.
Okay, shifting lower down. Chronic issues after lower GI surgery, especially pelvic cancer surgery, often functional symptoms, right?
Exactly. The guidance stresses actively identifying and managing these. The extent of surgery, where the join anastomosis is, really impacts symptoms and quality of life, and multimodal treatments usually mean higher risk.
What are the first steps for management?
Usually bowel habit training, diet changes, meds like loperamide for diarrhea, or fiber for constipation stepwise. A transit study can help sort out slow transit versus evacuation issues.
Evidence for biofeedback or irrigation.
Limited, according to the guidance. A stoma is really a last resort for severe uncontrolled symptoms.
Yeah.
And definitely use prophylactic laxatives with opioids. Interestingly, routine post-op proctograms or endoanal ultrasound don't seem to change much clinically in most cases. What about LAR specifically? Low anterior resection syndrome.
The guidance advises assessing risk before surgery using a validated tool. This allows for pre-op counseling and setting up supported self-management afterwards.
Do you need tests to diagnose LARS?
No, objective testing isn't usually needed for diagnosis. But if symptoms persist beyond about 3 months despite self-management, referral to specialists is recommended.
And always rule out other things that could make LARS worse.
Yes, definitely exclude BADED, PEI, SIBO. Management options for established LARS include pelvic floor exercises, bulking agents, maybe irrigation, and again, stoma in severe cases.
Okay, radiation-induced rectal bleeding. How to approach that?
Need investigation, usually endoscopy, because it's not always just telangiectasias. Diagnosis is mainly on endoscopic appearance. Biopsy isn't routine unless something else is suspected.
And the bleeding mechanism.
It's often ischemic, so interventions in ischemic tissue might not heal well, potential for complications. Informed consent is crucial before doing anything invasive for significant bleeding.
What if the bleeding is minor?
If it doesn't impact quality of life and malignancy is excluded, reassurance might be enough. Optimizing bowel function and stopping anticoagulants if possible helps reduce bleeding from telangiectasias. Sucralfate enemas can be useful too, short or long term.
Fistulae after pelvic radiation.
Rare, thankfully, and becoming rarer. First step, always rule out recurrence. Management needs an MDT approach. Control sepsis, understand the anatomy, optimize nutrition, then surgical repair aiming to minimize bowel loss.
And long-term surveillance.
Important. Increased risk of second cancers 5–10 years post-pelvic radiation. Encourage screening.
Let's touch on GVHD, graft versus host disease.
Right. Common after stem cell transplant. Lots of GI symptoms. Nausea, vomiting, anorexia, pain, diarrhea. Crucial to rule out infections first, especially C. diff.
Diarrhea in these patients can be tricky.
Very. Could be the conditioning meds, GVHD itself, malabsorption, SIBO, viral, fungal. Biopsies are often needed, but can be hard to interpret. Need expert pathology review.
Chronic GVHD.
Can affect the upper GI tract to mouth, esophagus with webs or strictures. Treatment depends on severity. Supportive care, steroids, other immunosuppressants. And remember, higher risk of second cancers long-term, so investigate new GI symptoms thoroughly.
Neuroendocrine neoplasms, NANs. What's the key message there?
That most GI symptoms are not hormone-related, so gastroenterologist involvement in the MDT is vital.
And treatments themselves cause GI issues.
Often, yes. Surgery, somatostatin analogs, they frequently lead to PEI, bad SIBO. The guidance says it's often okay to start PERT for steatorrhea after starting somatostatin analogs without needing a fecal elastase first.
Interesting. Other points for NANs.
Consider prophylactic cholecystectomy at initial surgery if long-acting somatostatin analogs are likely. Investigate new GI symptoms in non-functioning NANs for hormone changes or progression. Bulking surgery or systemic therapy might be needed for direct GI involvement. Surgery for mesenteric fibrosis is complex. Dietetics is crucial. Risk of short bowel. And again, increased risk of other cancers. Investigate unexplained symptoms.
You mentioned mesenteric fibrosis. Difficult to manage.
Very. Pain needs collaboration with pain palliative teams, dietitians. Early nutrition input is key. Resection might help symptoms, but risks short bowel syndrome. Surgery, even in stage IV, is possible, but it's an NN-MDT decision. Home parenteral nutrition is an alternative to high-risk surgery.
Okay, shifting gears slightly to palliative and end-of-life care. What's the focus?
Remote monitoring of PROMs, optimizing symptoms and quality of life. Consider palliative care referral if the risk of death within a year is high, say a 70%.
Key priorities.
Minimize pain, prevent opioid constipation, empirical trials for diarrhea, bloating, maybe rifaximin, bile acid sequestrants, purate can be considered, early iron for bleeding,
Malignant bowel obstruction in palliative care.
corticosteroids, octreotide might help. NG tube is really a last resort if the patient wants it. A palliative venting gastrostomy can relieve nausea vomiting if there isn't widespread peritoneal disease. It sounds like managing obstruction palliatively is complex, extremely. Needs specialist advice. Venting gastrostomy, parenteral nutrition might be options. Colonic stenting is controversial. Surgery might be considered if the patient is fit enough, and reversing obstruction allows more therapy.
Bleeding tumors in palliative care.
Remember, bleeding isn't always from the tumor. Consider other treatable causes, embolization or radiotherapy if you can find a source. For very short prognosis, pragmatically, transfusions and tranexamic acid, but watch for thrombosis risk. Endoscopic debulking, like with YIG laser, can sometimes help.
Looking ahead now, what does the guidance say about future perspectives?
Potential for lower radiation doses, though long-term effects aren't fully known. Research into therapies for ischemia, fibrosis, stem cells for repair, maybe. AI for advice.
Technology playing a bigger role.
Potentially, but also respecting patient preference for how they consult virtual versus face-to-face, using apps for monitoring adherence, symptoms, wider use of PROMs, developing regional specialist teams, and needing trained staff to act on all this monitoring data.
What about awareness and education?
Hugely important. Patients are more aware now. They shouldn't just accept bad GI symptoms. Access to support groups, good information, knowing signs of recurrence is key. Expert patient programs expanding.
And for us, the professionals.
Need clear referral pathways for complex toxicities. Investment in supportive care alongside new cancer tech. Basic assessment skills across specialties. Knowing when and who to refer to training needs to catch up.
Research priorities.
Need expertise, patient numbers, funding. Challenges with prevention studies, hard to define high-risk groups, lack of biomarkers. Recruitment for intervention trials can be tough, lack of ownership. Pharma focus often on survival. Time for oncology to invest more in supportive care research.
Then long-term follow-up.
Need standardized programs for monitoring long-term toxicity beyond just immediately after treatment. Finally, the economic impact. Cancer treatment is costly, but the cost of the morbidity, the ongoing problems, is poorly defined but likely enormous. Improving things nationally needs a mindset shift. Integrate survival goals with reducing toxicity and boosting quality of life.
So pulling all that together, managing these GI symptoms after cancer treatment, as this BSG guidance makes so clear, it's incredibly complex, isn't it?
It really is multifaceted.
It absolutely demands that patient-centered approach, thorough investigation, often early on to find the real underlying issues, and very often that seamless multidisciplinary teamwork.
Absolutely. And for us, as gastroenterology consultants, we have to recognize this huge range of physiological problems that different treatments can cause, and appreciate that just looking at symptoms isn't enough for
Which if
diagnosis.
different causes can look so similar symptomatically.
Exactly, which underlines why we need those comprehensive, evidence-based diagnostic strategies to really guide our treatments effectively.
And things are always changing, aren't they? Cancer treatments evolve so fast. Our understanding and management of the side effects have to keep pace.
hmm The guidance rightly says ongoing, high-quality research is just crucial to improve not just survival, but importantly, that long-term quality of life for the growing number of cancer survivors.
This detailed BSG guidance definitely gives us a valuable, comprehensive framework. It really prompts a key question for all of us listening, I think.
Which is,
How can we best take these detailed insights and integrate them into our daily practice to provide that more comprehensive, more effective, more patient-centered care for people dealing with these really challenging GI complications?
that's the crucial point. Maybe as you reflect on this, think about some of those difficult cases you've managed recently. How might applying this guidance more rigorously, perhaps earlier investigation or different diagnostic pathways, how might that have changed your approach? Or maybe how will it inform your management going forward?